بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الصلاة والسلام على أشرف الأنبياء والمرسلين. Good morning, everybody. Today our speaker, Dr. Nadim Islam, Associate Professor of Pathology and College of Dentistry, University of Florida. He will talk today about Potpourri of oral pathology. If you don't mind, welcome for Dr. Nadim Islam.
First of all, I would like to thank the organizing committee for inviting me, Dr. Shahrani, to be such an exciting host, all my colleagues, friends. Special thanks to Dr. Rafi for all the hard work he does. And I'm really excited to be here at ABHA for this first conference of King Khalid University College of Dentistry. I'm heavily invested in this college because I like, the leadership, the teachers, the staff, and all the hard work they do to make every student's life fruitful and successful. So, briefly about me, I graduated from dental school in India. Most of you probably know that, and then I took this difficult but very exciting journey to the United States, and I started my residency program at the University of Florida in 2004. I trained there, then I joined Indiana University, worked there for 5 years and 5 days, and then I was hired back by my mentors at the University of Florida, and I'm there for about 3.5 years now. It's been an exciting journey so far. And I was, talking to some of your colleagues and students yesterday, and they said, they are dreaming of being in the US and trying to pursue a career. To everybody, I just say, until you dream, you won't achieve. And don't ever leave your dream behind. So just continue the journey and do whatever is needed to get there. Thank you. So,
Pointer?
okay,
Forward, backward.
okay, cool. Thank you.
Do you do it?
Nah, maybe I can just do it.
I'll change the battery.
Okay. So, I'm presenting mostly cases that we deal on an everyday basis in our practice, and some of the cases that are sent over by, colleagues and dentists and providers for all the queries they have. And, we have a plethora of cases, probably at least 2,000 special cases, and I brought some of those here, especially interesting for general dentists and dental students, so that they have a little wider opportunity to look at few cases and decide for themselves how they should approach a clinical patient or scenario. This is the one. Okay.
Pointer,
Okay.
forward, backward.
It still doesn't work. It doesn't move from here also.
It should work.
It doesn't move from here also.
Okay.
Locked. Okay.
So now?
Okay. So obviously, Dr. Dolce showed you where we come from, and I won't take much time on that. That is Florida, and that is where, I don't know if you can see that. We are from. This is the university campus. Basically, it's a university town, so most of the buildings you notice in the campus is related to the university. It's a highly integrated system where most of the specialties work together. This is an aerial view. That actually is the dental school right there. This is the dental school building. And these are our students. We have a very diverse class, and we tend to mix as many more different nationalities and people from across the planet. In fact, as we speak, we just got a diversity award, a national diversity award. It's the only state university to receive this award in the US very recently, in fact, while we were at the conference. So these are some of my intent or intentions when I'm talking to dentists and providers and students is, try to look at the soft tissue when you are looking at a patient's mouth. I think that is very, very important. Try to identify the abnormal, and that will happen only when you have a very alert clinical eye to know what is normal. If you're used to the normal, the abnormal will jump out. So get first used to the normal. And you should always tend to think out of the box. I have noticed personally, whenever I thought out of the box, I reached a better diagnosis, I reached a better conclusion in finding the right answer. For me, most of the things follow a 2-week rule of thumb. And this goes mostly in clinical practice, where if you see a condition and you try to treat it and the treatment didn't work for 2 weeks, don't change the treatment, then change the diagnosis, because that means there's something wrong with the diagnosis, or maybe your approach is wrong. Ask someone, refer the patient, and things like that. And of course, the bottom line always is early diagnosis and prevention rather than intervention later on. So with that thought, we will continue into the lecture. This is a 12-year-old female, and most of these are actually stories because this patient was the daughter of a physician. So obviously she was examined by, physicians, pediatricians, dentists, and then she was in the 3rd month of her orthodontic correction when she told the orthodontist that she had this weird thing on her tongue for as long as she remembered. So the main thing here is the fact that being the daughter of a physician and having something probably from birth or even later, nobody ever noticed it. And it took her to tell the orthodontist that this is what I want you to see. And that's when he sent us the picture, and then we later advised a biopsy. So you can see this is a very vesicular lesion with all of those pustular areas. Some of these are red. And the biopsy basically showed the presence of this vasculature under the epithelium. I won't go into the detail of the histology because it could be beyond the scope of this meeting. But just for knowledge, those are vessels, those spaces, and that is the surface. The presentation like that can include a very broad differential, but in this case, it was what we call a lymphangioma. So not that it is a malignant disease or something, but at least we have a diagnosis. Of course, lymphangiomas of the tongue are very difficult to treat. Sometimes it may need multiple surgeries. And this, unlike the hemangioma, will not disappear or involute over a period of time. But the best thing to do is to wait and watch as the child grows up. But at least we now know that this was a lymphangioma. This is actually one of the most interesting cases, I would say, in my 11 years of oral pathology practice. So this patient is a 16-year-old female, and the story is very interesting. So she goes for an orthodontic correction to the orthodontist. The orthodontist notices, of course, she has to get her oral hygiene cleaned and everything, but the orthodontist sends her for the hygiene maintenance, and she lands up in the periodontist's office, where while doing what they had to do, the periodontist notices these 2 small swellings on the commissure. So they think it is a fibroma, which anybody would think because it is an area where you tend to chew. So the periodontist biopsies that and sends us one of the specimen. So these are bilateral commissural fibromas. Now, when we look under the microscope, what we saw was this collection, haphazard collection of neural tissue or nerve tissue surrounded by a thick coating, which is the perineurium. So now this is the presentation of what is called an oral mucosal neuroma. What I did was I called the periodontist. I said, did the patient have another growth on the commissure on the other side? And he said, yes, but why do you ask that? I said, because this is a very specific entity, and I wanted to confirm when you have these bilateral commissural fibromas, there's a tendency that the patient may have a very specific condition, and we'll come to that. So this is what we saw under the microscope, all of these nerves. The diagnosis was mucosal neuroma, and those neuromas can be found in the eye, in the skin, on the conjunctiva, all of those areas. But they are very specific and indicative of a condition called multiple endocrine neoplasia type 2B, okay, or type 3. Now what is that? It's a syndrome where patients may have tumors of neuroendocrine tissue. So it's also called Sippel syndrome. Bilateral commissural neuromas or fibromas can be seen, and these patients generally are young women, okay? And what happens is, as a sequelae of disease, almost up to 100% of these girls will tend to develop a thyroid carcinoma and will die by the age of 21 years. So then we referred this patient for evaluation of the thyroid gland, and they found she had medullary carcinoma of the thyroid, and this is actually the biopsy of the thyroid gland. You see this collection of, colloid, and this tumor arises in the parafollicular or C cells, which produce calcitonin. So these are the histology of the thyroid, and we did a calcitonin check. You can see that immunohistochemistry shows positive reaction, that is overproduction of calcitonin. Patient was confirmed for medullary carcinoma of the thyroid. Neck dissection opened 26 positive nodes. So I don't know what happened later, but clearly the patient was undergoing metastasis at the age of 16. Now, the reason to present this case is not to teach you guys about multiple endocrine neoplasia, but to make you aware that simple growths like fibromas on the commissure could have been noticed by the pediatrician, by other dentists, and this patient could have had a prophylactic thyroidectomy, which is the standard of care in these patients. So when a prophylactic thyroidectomy is done, you can save the patient. So this is a high impact case where being alert over simple things can sometimes, take care of the patient and, keep the patient alive and healthy. This is a 60-year-old white male, and in this patient, there were lesions for 3 months duration. The patient was immune suppressed. He was a long-term smoker, and he presented with these ulcers of the tongue, the floor of the mouth, and the pinna or the ear. So of course the broad differential includes multiple things such as the long list, but you have to remember squamous cell carcinoma does not appear multifocally, and these were dirty looking ulcers. The good thing to notice in an ulcer like this is the clean margins. Cancer does not have this systematic or well-defined borders. So ultimately, we did a biopsy on this patient, and what we found was these fungal elements in the HNE, which was stained by a PAS stain and a GMS. So this was actually a case of histoplasmosis. So of course, it may not be that common in Saudi Arabia, but when you have these long-term ulcers that are very cratery form or deep, you should keep deep fungal infection in your differential, and especially if the patient is immune suppressed, because these fungi otherwise will not present. In the Mississippi, Ohio River Valley, these are actually endemic. Most patients are infected, but they do not present because the body walls it off. Once you're immune suppressed, it presents in this diseased form. This was an 81-year-old female. She had persistent painful ulcers for about 5 to 6 years, which were recalcitrant. So any amount of topical steroids, or treatment, which usually is the protocol for lichenoid lesions, did not work in her case. So she had this buccal mucosal ulcerations, posterior aspect of the mouth, tongue lesions that were pretty horrible, and she was in great pain. Now, for any lesion like this, there's a standard biopsy we do for H&E, and you start to see this very thin epithelium with lymphocytic infiltrate. I'm sure people who are used to lichen planus understand that, and you can see the separation there. So that is where the surface epithelium is being denuded because of the condition or the nature of the disease. And there is that lymphocytes which are actually attacking the basement membrane zone. You even see the retipex just like a lichenoid lesion. But in this case, what we did was we ran a DIF, which is a direct immunofluorescent antibody study. And we found there was strong IgG distribution as well as fibrinogen. And this is very specific, especially the pattern of distribution, which is called perinuclear distribution of the antibody. And that is seen in a condition called chronic ulcerative stomatitis. So when this was diagnosed, the patient got what is called hydroxychloroquine, which is actually an anti-malarial, and that works wonderfully for these recalcitrant cases. And the patient actually had complete resolution of the lesion about 3 weeks later. So you can see the ulcers are now closing up. You don't see the profound aggressive nature of the ulcer anymore. So keep chronic ulcerative stomatitis in your mind when you're treating, especially for oral medicine people, patients who are females, who are perimenopausal, and who have these persistent ulcers which do not heal with topical steroids. So keep CUS in your differential. And I think I wrote a paper on that way back in 2007, which is kind of a review article, but it also presents 4 new cases. This is a 79-year-old male patient with a 12-year history of mandibular transosseous implant. And you can see there is some hyperplastic tissue there. The radiograph shows, inflammation, almost a very hazy or fuzzy moth-eaten kind of radiolucency there. Obviously, the implant failed. And when tissue was submitted, we found this, proliferation of very atypical epithelial cells. So we were suspecting a malignancy, something like an epithelial malignancy, but it turned out to be a metastatic adenocarcinoma. So again, it's not a difficult case. I mean, it's a simple case of implant failure because of a malignancy, but what is the take home is peri-implantitis could not always mean a benign process. Always consider a malignancy, especially in older people above the age of 70, that there could be something else going on. It could be a metastatic lesion. It could be actually an undetected carcinoma where the implant was placed. And we have had a number of cases where even re-implantation was done with bone graft, but it was actually, a simmering carcinoma beneath. So the implant kept failing, but it was a verrucous cancer, so, it did not show distant metastasis immediately. And then later it was found, even when we went back to the first X-ray, that you could see that there was bone destruction related to the malignancy. So keep peri-implantitis and look at it very carefully if it is an older person. This is a 32-year-old female, presents with multiple linear ulcerations, and it is all over the mouth, especially the gingiva and vestibule. So as you can see, you have these almost forming lines. We call it linear or serpentine pustular mucositis. And there is a plethora of entities that can present in that way. But if you look at the history, she also has history of recent gastric problems. And at that age, a young female with that kind of oral presentation and with problems in the bowel, you must bring Crohn's disease into your differential. And that is the main purpose of this particular case, is where you think about Crohn's. And in Crohn's disease, people may develop this ulceration or mucosal erosions anywhere from the mouth till the anus. And 30% of patients of Crohn's will present with some kind of oral ailment before actually the GI lesions. So that is where we can step in and do a better job. Some more pictures of the same condition. And I'm showing this so that you just remember how it looks clinically. You know, the tendency of this lecture or any oral path lecture is not to make everybody a pathologist, but just to know, at least, you know, to understand the nuances of the abnormality you're looking at, and which can help the patient in a better fashion. So you can see again that typical yellowish red presentation, and we call this pustular mucositis. These are not really open ulcers, but they are small abscesses or micro abscesses that have these eosinophils filled within those areas. Again, the same presentation, looks a little boggy, almost like, you know, velvet. Moving on to the next case. This is a 55-year-old Caucasian male, presents with a red erosive lesion on the posterior mandibular gingiva. And what we noticed clinically was this almost punched out gingival lesion. And the patient had bad oral hygiene, no doubt about it. So the oral hygiene was maintained and the patient was asked to come back. And then later on, the bone destruction continued. So obviously, you know, the 2-week rule of thumb, you don't get the necessary outcome. And, you know, biopsy was performed, and this turned out to be actually gingival squamous cell carcinoma. So something to remember, if you see periodontal destruction or inflammation which is not really matching the oral hygiene or the care you provided, and patient is older, you know, try to think about gingival squamous cell carcinoma. They're very innocuous. They are not very evident. They don't produce much symptoms, but they're still there. They will keep simmering. And in some patients, if you extract the tooth, it is the socket that will not heal. Instead, you will have this hyperplastic tissue coming out, which is actually just an exploding squamous cell carcinoma. Some more pictures just to, you know, notice how, you know, it's boggy and dirty looking. That is a typical gingival squamous cell carcinoma. This is a 76-year-old female, presents with 1-year history of sore gums, which tends to bleed easily. And there is some sloughing. So you can see the best way to describe this presentation is bloody blister. You know, that's a word we use very often. So if you see clinically someone who is middle-aged or elderly and has this long-term history of, you know, bleeding gums, or, you know, gums that present with almost like a blister form, think about mucous membrane pemphigoid. And the histology shows complete epithelial separation. You have this fibrinous exudate, you know, in the denuded areas, and the, you know, antibody testing shows positive IgG, IgA, and C3, especially in the basement membrane zone. So that is confirmational for benign mucous membrane pemphigoid. And all of those could be in the differentials, but the diagnosis in this case was BMMP. Some people don't want to use the word benign because sometimes patient faces a lot of morbidity, but that is the scientifically acceptable term. And I would always remember this word clinically, bloody blisters. Those are almost pathognomonic for the condition. So if you see bloody blisters, your top differential should be pemphigoid. And what is the necessity to identify this condition? Because there is an impact associated. These patients tend to develop eye lesions, okay, and those are called symbol ferrons, and that will lead to blindness. So once you have a diagnosis report of BMMP, make sure the patient is being followed up by the ophthalmologist, you know, to avoid any blindness. This is another same case just for clinical presentation. You can see how fiery red that is. This is a 48-year-old Caucasian female, and she was referred to the oral surgeon for treatment of the anterior mandibular vestibular lesion. And I'll quickly show you the lesion itself. So you can see this almost yellowish, nodular, almost like a stuck-on lesion in the junction of the mucogingival area and the vestibule. And there might be multiple differentials, but this was a very interesting case. And to tell you frankly, we are getting at least 2 such cases every week in our biopsy service. And what we saw under the microscope was these, mucoid material which is being eaten away by multinucleated giant cells. All of those round circles with those dots are actually multinucleated giant cells. So this is a foreign body granuloma which the body is forming to clear out or attack a filler material. Tissue augmentation and filler are being commonly used now, and there are multiple types. So this one basically was Redis, which is an injectable filler material. If it is not placed properly in the location it is supposed to, it may displace or fall off in another location, and that is when you tend to see those lesions. So if you see something like that which you cannot explain, a good history taking maybe can actually bring out the fact that the patient got a filler. The granuloma formation, by the way, is something that is desirable. It is not a disease. And this is something that got cleared in my mind about 2 or 3 months back. I was going through a paper where the puffiness or the filled look is something that is the granuloma. So we want the granuloma to happen, but it has to happen in the right place, not in the wrong place. And then over 3 to 6 months, the giant cells will engulf and completely resolve this condition, and that's why we need a repetition of the filler process. So this was actually a reaction to the filler material. This is a 55-year-old Caucasian female with an unremarkable medical history. Patient is a non-smoker. So why it is important to mention, I'll show you the clinical pictures. She had, this particular presentation, and just below the pontic you have this subtle radiolucent area which was explored, and then when it was cleared out you have this almost blackish tar-like material that was found there. Now it could be any of these entities, but it was a condition called myosferulosis. And what this is it's a benign condition because previously oral surgeons and many of the procedures were backed up by putting an antibiotic material in the socket or in the zone of the surgical procedure. So the body tends to again resolve that, and the red blood cells kind of change over and form what are called collection of marbles, which you can see under the microscope. So you can see this is just normal connective tissue. That is the material, which is the antibiotic petrolatum based material. And then if you go to the higher power view, the small circle you see, those are actually red blood cells that tend to form this round masses because they are altered by this material. And if so, any unexplained radiolucency in a previous surgical site, you don't have to really go in. If you get a good history, you can call the treating clinician and confirm that something was applied there. So that is another approach where you can save unnecessary surgery. By the way, this picture was taken by an iPhone directly from the microscope. And I don't know if you can appreciate because of the screen, but I can see a very clear view in the screen right here. So, and I kept the circle intact. So you can have something like that radiolucency, distal to tooth number 17 right there, actually 18, and then those need not be actually explored because that is myosferulosis. But again, your history taking is very important to reach that conclusion. This is a 16-year-old young white male presented with this lesion of the lower lip. So the interesting story about this is I keep flying back and forth to Indiana. One of my ex-students wanted to learn how to perform a biopsy. She scheduled this patient and said, I would like to do biopsies, can you help me? And she did this biopsy under my guidance. And our differentials included all of these entities which you can expect to see on the lower lip, okay? So you can have a fibroma because of trauma, a mucocele, this patient is young. A pyogenic granuloma can be in any mobile mucosa. A granular cell tumor, not very common in the lower lip, but still something to be considered. And then a plexiform neurofibroma. And in this case, the diagnosis was a plexiform neurofibroma. A lot of you who have not or are not refreshed with this particular entity, this is again a pathognomonic condition for diagnosis of neurofibromatosis type 1. So you can imagine the excitement of this new dentist learning how to do biopsy for the first time, and she diagnoses, or she actually submits a tissue that is diagnosed as plexiform neurofibroma. So this was the first diagnosis. Then the patient is referred for evaluation, genetic testing, and it's confirmed for NF type 1. So that is the kind of impact oral healthcare providers can make on people's lives. And you can imagine a 16-year-old definitely has gone through physicians, pediatricians, general dentists, and many other people. But this was missed because this is definitely present from birth. It's not like it's happening right then. So of all the things that you can see in neurofibromatosis type 1, what really affects us or what makes it important for us as oral healthcare providers is to be again alert, because these patients can have oral neurofibromas. They can have enlargement of the fungiform papillae of the tongue. So if you're alert and look at the soft tissue briefly, I would say 30 seconds is a good amount of time if you know what is normal to identify the abnormal. And then there are some radiographic findings, enlargement or branching of the inferior alveolar canal. You can get, the concavity of the ramus, all of those things. If you're alert and catch those, probably you can evaluate the patient further. That is how the oral neurofibromas look like. And any of those small vesicles you see have a tendency to become a larger neurofibroma. This was on the same case, a different case where this lady is 59 years old and she had all of these growths on her face. When we asked her, she said, "Oh yeah, my doctor said these are all moles and I'm having this from birth." What kind of moles are present from birth, So we biopsied that, and that was again a neurofibroma. Patient was evaluated and found to be neurofibromatosis type 1. And this is the US we are talking about, and this is a 59-year-old female. Later she said she actually has birthmarks in her body, on her back, and birthmarks goes very well with neurofibromatosis. As you know, we call those cafe au lait pigmentation. So, not that she was having any of the complications, but at least she had a diagnosis. Those were definitely not moles as she was being told. Patients can have actually lesions up to 100 or 1,000 of these neurofibromas. That is a typical cafe au lait pigmentation or coffee with milk. For some reason it is called to, similar to the coastline of California. You can have eye lesions. Moving on to the next case, 65-year-old female has a 3-year history of lesions in her mouth. Diagnosis, multiple diagnoses of papillomas and lichen planus. But obviously these lesions keep coming back. Again, the importance of this presentation or this case is for you to understand that because of no explainable reason, the patient is a non-smoker, she's a middle-aged female, she doesn't drink, no abuse alcohol, nothing, and you have these lesions which are biopsied and these keep coming back. All of those right there. So they're slightly papillary, leukoplakic. You can see all of those in the gingival margin. So, this could be in your differential, but this is a very specific entity when you see those clinically, and you should always keep proliferative verrucous leukoplakia in your mind. Now, one may think, okay, it is leukoplakia, it is proliferative, what's the importance? Again, the importance is you need to remove those, even though these are recalcitrant, and these are absolutely relentless lesions which will keep coming back. So, it's a chasing game clinically. We have about 27 such patients we are following in our oral medicine clinic. I have about 13 and my partner has about 14 patients. So 2 of those have already undergone transformation, because PVL, whatever you do, will convert into either a verrucous carcinoma or a squamous cell carcinoma. It is only when and at what duration. So these patients keep coming back, we keep cutting those tissue out, as much as possible, and then 3 months later. So these are all kept under 3 months follow-up, and what we call is, watch these patients like a hawk. So you have to watch every area and keep cutting it out. But 2 of our patients have already shown transformation. Some more of the same pictures. So something like this you should embed in your minds. And I'm sure in Saudi Arabia you may tend to see these. And so at least you will know, that this is not something usual. You don't tend to see keratin of the mucosa like that. That kind of keratin is supposed to be present in the sole of our foot, not in our mouth. And tongue especially is a high-risk area. You see white lesion like that, which is getting verruciform or papillary, definitely a high-risk location and tendency to convert. This patient is 77-year-old, had bilateral diffused tongue masses. I will actually go to the picture itself. And the patient had been, the last 2 to 3 years, visited other physicians and dentists, and he kept saying, my tongue feels heavy. And clearly, he was chewing on his tongue. You can see the ulceration on that side. And it's been so chronic that you now see keratinization around the ulcer. Clinical examination also revealed these petechial, marks or hemorrhagic marks on the scalp. So there was multiple differentials thought of, and obviously we performed a biopsy. And this is again an iPhone picture. This is a smaller picture showing the surface epithelium, and then a wider one. If you look at these arrows and you see that pink zone around the blood vessels, that is a collection of a material which we call amorphous eosinophilic or pink, which is very much like amyloid. Amyloid is nothing but a starch-like material which the body produces under certain conditions. And how do we confirm that? We put what is called a Congo red staining on this particular section, and then we look at it under polarized light. So what you see here is called apple green birefringence under polarized light, and that is confirmational for amyloid. So this patient definitely had amyloidosis, but the further exploration necessary is amyloid is specific to certain entities. We don't know why it is deposited, but multiple myeloma is one of the major reasons. You can have patients who are on dialysis, patients who have sarcoidosis or chronic infections like TB. All of those patients can have amyloidosis. I'm going on to another case, and then I will tell you what these two cases were. This is a 70-year-old female who was referred by an endodontist because the general dentist referred the patient after multiple endodontic therapies as the periapical radiolucency was not healing. And she also presented with pathologic fracture. So this was the radiolucency and the initial radiograph after the first endodontic treatment. Second, and then you can see, you don't get the desired result, but you keep treating because you have some questionable vitality testing, but that's where you have to think out of the box. And then this was sent to the endodontist who referred the patient. We got a biopsy. Patient already on skull view showed these, punched out erosions of the skull. This is how the pathologic fracture would look like. And look at the macroglossia. You can see that clear ulceration right there because the tooth is literally closing on these. So this is a case of a plasma cell malignancy, which is multiple myeloma. The previous gentleman also had multiple myeloma, and this patient also had multiple myeloma. And the jaw lesions were the first lesion in this lady. And for that patient, the amyloid diagnosis was the first diagnosis for multiple. These are all atypical plasma cells which you see in these patients. The plasma cells look normal, but they behave abnormally because they keep producing immunoglobulins which are of no use. These are nonsensical proliferation. So again, important for oral healthcare providers, jaw involvement of multiple myeloma happens in 30% of the cases. So more glory to us, but if we are alert, then it will really help the patient because you can nail the diagnosis. And then of course, amyloid deposition on the tongue is an important aspect of this disease. There are other things like Benz-Jones proteins or myeloma proteins that can be present in the serum and the urine. Of course, with whatever modern advances that has been made, the disease is still a killer. Prognosis is poor. And I don't know if you know this, but one of the biggest fundings for myeloma research comes from the widow of the Walmart owner, Sam Walton. So hopefully someday we will have a breakthrough in this particular disease. This 22-year-old female has an asymptomatic radiolucent lesion involving the mandibular canine tooth. There is no expansion and the tooth is very much vital. So that is very important. The tooth is vital. So you have this periapical lesion and the tooth is vital. But what does the patient get? There you go, an endodontic treatment, not required. So if you know what you're looking at, you can stop yourself from doing the treatment. Look at the lesion. The patient, the tooth is not involved. You have this nice, very well-defined radiolucent / radio-opaque lesion, which if you use your imagination can be called to match what is called a target or bull's eye lesion. And the biopsy was performed and this is what we saw. So we have these almost ginger root-like formations of bone or cementum in a highly cellular stroma where you can see this pink collagenous material which is surrounding all of this. So this is a classic presentation of a cemento-osseous dysplasia, which is a type of benign fibro-osseous lesion. I know these are big names. If you remember, fibro-osseous means there is bone which is osseous. It is being replaced by fibrous tissue and vice versa. Now the bone or cementum is the hard part and the soft tissue is the soft part. So that is why you see a mixed radiolucent and radio-opaque lesion. But it always has that tendency of a well-defined nature and almost like there is a border around the opacity, and I'll show you more of these. So this is an entity which is called periapical because it's in the anterior quadrant. There is something called focal, which is usually associated with the second molars in a middle-aged white female. And there's another entity called Florid, where the same thing is seen on any quadrant. So it can involve multiple quadrants, including bilateral or even maxillary. Just some more radiographs so that you can, have a kind of idea of what's going on when you look at these X-rays. All of these have this, mixed radio-opaque, radiolucent shadow, and you have this thin demarcating line. Again, this got endo treatment, but obviously to no avail because the treatment for this condition is nothing. You just watch the patient, that's all. In fact, going in and doing a serious biopsy will cause more harm than good. So if you can make a strong presumptive radiographic and clinical diagnosis, you just leave the patient alone. The patient doesn't need to be treated for this. Some of these may even present as idiopathic osteosclerosis, or if the tooth is involved, you can call that condensing osteitis. But we know this was diagnosed as cemento-osseous dysplasia. So there is a lot of overlap in that area where you see this mixed radiolucent, radio-opaque lesions. This is the same case, but in a different patient continuing. And this patient was a middle-aged African-American. She's undergone multiple biopsies, actually, because of what clinicians were noticing. Now she's in pain. She almost has, she's febrile, and she's really suffering. And that is the area which now starts to show some buccolingual expansion. Right there. And she's in great pain. So this is how a radiograph looks like. You can see it's almost like something is eating away the jaw. And here there is a tendency or potential focus of pathologic fracture. So now what is happening is this patient actually had what is called florid cemento-osseous dysplasia, which is again very easy to diagnose putting 2 and 2 together. This is a middle-aged African-American female. You have this target or bull's eye type of lesions. Leave the patient alone. You don't have to do anything. But she was constantly biopsied, and you can see where she went with it. So this, we did more harm than good for the patient. So previously this condition used to be called sclerosing osteomyelitis. But the most important thing to remember is just leave the patient alone. No need to do biopsies or extraction of teeth in that. And there is one paper I actually wrote on this where multiple teeth were endodontically filled, like incessantly, thinking these are all periapical lesions, but they were all cemento-osseous dysplasia. This is a good radiograph to understand florid cemento-osseous dysplasia. So you can see each of these teeth have this, almost like somebody is wearing shoes. The teeth are wearing white shoes right there. But you can see this radiolucent rim surrounding the radiopacity, and that's a good clue that you're dealing with focal or florid cemento-osseous dysplasia. This is a similar patient, but now this is called end-stage cemento-osseous dysplasia. Because now there are no teeth left, you don't see that, bullseye lesions, but the whole jaw is being, replaced by this almost mottled radio-opaque bone or cementum. And some patients may even complain that they have, small particles coming out of their alveolus, which is okay. If you have a radiograph, you can still make a strong presumptive diagnosis. And generally, we are so biased with these lesions. We get a biopsy, we look under the microscope, and the clinician maybe has not mentioned the race of the patient. We'll pick up the phone and say, hey, is the patient a black patient? Yes, okay. So, you can almost find out the race of the patient from the tissue rather than the other way around. And only the focal one, which is associated with the second molars, that is generally seen with middle-aged white women. So, there is such a strong propensity that you can reach the history from the diagnosis. So you can actually work your way backward. This is a very interesting case, 65-year-old patient, and the patient swears that his teeth are separating. But his dentist assures him that this is not the case, and he did multiple crowns. And then later, as they separated with the crowns, they did more crowns with increased mesiodistal width. And that was the patient's maxilla. So clearly, to any alert clinician, I would expect they would identify that this is not a normal alveolus or gingiva in the maxilla, because there is loss of stippling. None of the normal textures which you expect in healthy gingiva is present. And you can see there is something growing en masse that is causing the teeth to spread out. Of course, biopsy was performed. This was the radiographic presentation. And this is a condition called Paget's disease of bone. So the patient actually had developing Paget's while he was getting these multiple crowns for his separating teeth. So again, look at periodontal tissue, because there might be much more story there rather than the tooth. And I'm not saying cosmetics is not important, but oral health also involves the periodontal area. What happens in Paget's is basically an increased turnover, because bone keeps forming, but there is almost like a irrelevant breakdown. And so the net effect is more deposition of bone or increased turnover of bone. And that is why you saw that haphazard white or radiopaque area in the maxilla. So the net deposition is increased bone density and mass, and that's why you get that proliferation. So think of Paget's if you're dealing with an elderly male person and you're getting this kind of complaint where either the dentures don't fit, or they're getting loose, or the crowns are getting separated, or the teeth are getting separated. And Paget's will also have this osteophytic bone deposition. You can even get hypercementosis in these patients. So that is again something which, as oral health providers, you will be seeing. So keep hypercementosis unexplained with that kind of bone deposition, elderly male patient, keep Paget's in your differential. This is a 12-year-old male, has a history of premature spontaneous tooth loss, facial swelling, and halitosis. Obviously, you can see that right side inflamed and swollen. There was skull lesion. And then, the jaw, multiple jaw lesions with a typical look of tooth floating on air appearance. And there are only quite a few things which you should consider when you see a radiographic presentation of tooth floating in the air appearance. Okay, some of it may be, something like Papillon-Lefebvre syndrome, which is aggressive periodontitis. You can have cyclic neutropenia. You can have Ewing's sarcoma. You can have Burkitt's lymphoma. And then this condition where we saw collection, I'll show you a high power field, a collection of these almost histiocytic cells with these pink cells which are eosinophils. And if you notice this large cell right here, I don't know if you can see, but right there, some of the cells have a kidney bean-shaped nuclei. Those are called Langerhans cell. And this condition is called Langerhans cell disease, or histiocytosis X. So you have to keep in your differential for tooth floating on air, radiographic appearance, all of those things which I mentioned. But this is definitely a malignant neoplastic proliferation of Langerhans cells. Some patients may have spontaneous resolution, but in children especially, these behave very aggressively and have to be treated aggressively. This is the 10-year-old male, complains of the cheek swelling and a mass sensation on the maxilla. So there is some swelling there. Radiographically, you can see that hazy, almost ground glass opacity there, right there on the left maxilla. So this is not a major challenge because ground glass opacity, one of the first things you should think about is fibrous dysplasia of the bone. So in this patient, it involved only one bone. We tend to call those monoostotic fibrous dysplasia. Again, the histology is pretty easy. We see these big particles or trabeculae of bone, which does not have any osteoblasts rimming the bone. So it's bone formation without osteoblastic rimming, and that is diagnostic for fibrous dysplasia. There are polyostotic types, which can involve multiple bones, but this was just one bone. And this also can have cafe au lait pigmentation, especially the polyostotic type, which is the McCune-Albright syndrome. This is an 88-year-old female, and I'll quickly go to the clinical picture because it's important. Obviously, it was a lip lesion that looked like a mucocele, almost looks benign, but this is an 88-year-old patient. When you deal with a patient above the age of 70, always think of something bad unless ruled otherwise. You know, that's how you change your differential. So this turned out to be a rare malignancy called Merkel cell carcinoma, which is not very common, but it's a neuroendocrine carcinoma, very locally destructive and tends to go to the nodes. So this was a good diagnosis. I will not go into the histology, but any lower lip lesion that is unusual in an elderly person is not a mucocele because mucoceles do not happen in older people. This is a 13-year-old Asian male, has a highly vascular gingival mass, and the status was post-orthodontic. And you can see the lesion right there. It's kind of papillary, very red, multiple differentials, but a new entity that I bring to the picture, which has been actually reported in 2007. So you see this almost blunt papillary projection of epithelium, edema, spongiosis, and very narrow small blood vessels. So this is a specific entity which has been recently reported, and it is called Localized Juvenile Spongiotic Gingival Hyperplasia or Gingival Papilloma. So it is not virally induced, it is a reactive lesion. Whatever patients we are getting, almost one case every week, are either during orthodontic therapy or post-orthodontic brace removal. So much so is this diagnosis strong that when we look at the histology, pick up the phone and say, can you tell us more about this patient if the patient is undergoing orthodontic treatment or has just gotten done with it? And the provider will say, yes, the patient has braces, or so you can just correlate that way. So Darlene basically reported this in 2007. So keep this particular entity in your differential when you're dealing with small kids, especially in the anterior maxillary gingiva. This is a 19-year-old lesion of the right anterior tongue dorsum. You can see that mucosal lesion right there. Histology showed this epithelial proliferation, which we call pseudoepitheliomatous hyperplasia, but actually the neoplasm was right there in the stroma, which is these granular cells, and this is called a granular cell tumor. It's a benign entity, submucosal. Most common site is the tongue dorsum. So just remember that. And these are all iPhone pictures, by the way. The problem with this is many of the general pathologists have previously diagnosed these as oral cancer, and patients get unnecessary cancer surgery. So the one most important thing you have to remember is the tongue dorsum is a low-risk site for squamous cell carcinoma. So if you biopsied a lesion from the tongue dorsum and you submit it and the pathologist calls it squamous cell carcinoma, you need to question the diagnosis. And it is always a best bet if you can submit it to an oral pathologist. Because even though the presentation is like invasive cancer, it is a benign entity. And we are uniquely trained to identify that. This was another case on a black child. This is a 65-year-old that presented with this bony lesion. And I'll quickly go into the lesion because we may be running out of time. So these are all bony protuberances that are closing the self-cleansing areas under a pontic. Radiographically, you can see this almost extension or deposition of extra bone. This is a reactive lesion, which is called subpontic osseous hyperplasia. So keep that on mind. If you see this bony protuberance, it is probably reactive related to stimulation of the PDL by either a malposed crown or a not very well formed bridge. And you should keep that in mind. If the self-cleansing area is completely closed, you need to go in and clean it up and open it up. Otherwise, it doesn't need any treatment. I did publish that, 3 extra cases of those in the literature. This is another one showing this protuberance, and then the histology shows exactly the dome with normal bone, and you have this fibrofatty marrow. So this is another case of subpontic osseous dysplasia, hyperplasia, and another one right here. So something like this where you still have the open space, your self-cleansing area is still there, so you don't have to really worry about that. I think this may be the last case. This patient is 57-year-old presenting with this mass, and let me go to the case. So the patient probably had an anesthetic injection for extraction or a dental procedure, and then 2 weeks later develops this huge, necrotic ulcer on the palate. I mean, looks very worrisome, it's very scary. On biopsy, what we see is this very well preserved acinar area where the salivary acini are, and then you have these ductal cells that are showing metaplasia. So think about this entity called necrotizing silometaplasia. If you see something which is odd in the palate, you see an ulcer, get a good history. Maybe the patient was with a dentist or for some other treatment, got traumatized. Even pizza burn can do that. When you eat hot pizza, generally sticks, the cheese is warm and it sticks to the palate. That can take off this necrotic tissue, but it will generally heal by itself, okay? Anything in the palate, squamous cell carcinoma is not a good differential because palate is a low risk site. You can get salivary neoplasms, but this is a benign entity. So if you can have a good history, you can actually, you done? Okay, I'm actually done. So there is no real treatment, it's self-healing. Thank you.
Thank you very much, Dr. Nadim. It's very interesting presentation. And if you don't mind, we'll open the question time. Good morning again. Question start. If you have any question regarding this presentation for Dr. Nadim, please. We have mic for lady and mic for gentleman. Yes, please.
Good morning. Thank you for your plethora of presentations of various lesions. I have 2 questions for you. First, about florid cementosseous dysplasia. Florid cementosseous dysplasia, even Indians who have a black skin color and descent from Africanized Indians, we have such cases in them. In fact, I had a case in which she continued to develop loose teeth because of the lesion. But once she lost all her teeth, the symptoms subsided. So can you say that this lesion is a reaction to the teeth itself?
No. What happens when you say loose teeth? When you say loose teeth, what is happening is there is inflammation. The inflammation is acting as a stimulus to ignite this lesion more and more. So it will take away the teeth. Once that is done, it closes up and it will be dormant. That's how it progresses. That's why we say don't biopsy, because when you biopsy, you're taking out tissue for exam, but you're actually creating more disturbance in that area. So better to just leave it untouched.
Okay, you said don't biopsy and don't extract, but if the tooth is mobile and loose and it's a hindrance.
But the tooth mobility is because of her bad periodontal health. That means there is a simmering chronic inflammation there that will keep stimulating this condition. And it is like a chain reaction. So it will It will be relentless until the teeth are gone.
Okay. Second question is about malignant lesions and carcinomas. Can you say that if you do an incisional biopsy of a carcinoma, it ignites it to grow faster?
Say that again?
Carcinomatous lesions in the mouth, if you do a incisional biopsy, like you disturb it, it tends to grow faster. Have you noticed this in lesions like squamous cell carcinoma?
See,
Thank you.
the very decision whether you will do an incisional or an excisional depends on the size. Okay? So what we personally do is, if I get a patient in oral medicine, open the mouth, I see this is, I know 90% this is cancer, I immediately take the patient, walk the patient with me to oral surgery and say, you know, this is a cancer, schedule the patient. So instead of putting the patient through 2 procedures, you know, get the excision out. Because it is already looking bad. There is bone involvement, for example. The radiograph shows bone erosion. If it's a small lesion, you can do an excisional, then you don't. But you know, the fact, incisional biopsies are known to spread tumors, but I don't know whether they grow the tumor. That I don't think so happens. Cancer is anyway, you know, an incessant growth, so it will tend to grow.
Because the thing is that we have seen that if you don't take the patient for further treatment after an incisional biopsy, the tumor starts to become bigger and bigger, maybe because it's stimulating new cells to come
Maybe there is angiogenesis and things like that. Yeah, that can always happen. But I don't think you can actually stimulate a cancer to grow. You can spread it. Yes, incisional biopsies can spread it in different layers of the tissue. Because you go in, when you draw out, you know, you are probably spreading the cancer. But if you have a good, if it's a benign lesion, you treated the patient. If it's malignant, the patient would anyway undergo excision. So, you know, the cost-benefit ratio is always there.
Thank you.
Thank you, my colleague. Thank you, my colleague. Any question? Yes, please.
Morning, sir. Really nice presentation, a lot of interesting cases. I have just one question regarding proliferative varicose leukoplakia. You said every 3 months you have to excise the lesions.
If it comes.
If it comes, yes. If it recurs, and it has a higher recurrence rate too. What is my question is, what is your opinion regarding laser photodynamic therapy, or since it is an HPV-induced lesion, oral antivirals?
It has still not been conclusively proven that there is HPV involvement. You know, there are some papers that claim it, but their own studies have shown that there is no conclusion, there's no real conclusive evidence. So that is out. The laser photodynamic therapy is definitely something that is practiced, but laser ablation and things like that tend to spread it around also. So it's almost like, you know, this medication will help me, but it is a poison. It's almost something like that. But because these patients undergo so much of morbidity, that whatever can help, we use that, you know. So what you're saying, yes, laser therapy is one of the protocols in treatment. But I personally believe in cold scalpel, cold steel, because that way you have a clean margin. And you know, we know, and we keep taking pictures, you know, of every stage. So if the patient comes back in 3 months, we are still taking clinical pictures, nothing shows up. Then in 6 months, even if a spot shows up, we just remove it. So we don't wait for it to become verruciform or papillary or something, just get it out. So the protocol from our side is, it's like a chase, you know, you're chasing the lesion basically. So one day the lesion will win, but as long as possible, we just keep chasing it.
Okay, we have still a chance for another 2 questions. To be fair, female side, any questions? I think you're still sleeping or what? Okay. No more question? Thank you very much, Dr. Nadim. You can have a seat until Dr. Muhammad. Any question from female side? Mike, please. Where? No, I don't think so. Okay, by the way, no problem.